This activity that we are doing is going to help us to identify cases that are within the communities, and then we'll be able to actually reduce the cases that come in late, because once they come in late, then the complications are many, the cost of care is too much, and of course then the death of life is unnecessary.
I'm called Dr. Ezekiel Mopere. I am a pediatrician and a medical epidemiologist. I teach at Makerere University, College of Health Sciences at Mulago, and I am currently the head of department. However, I'm also involved, and I have been working with the Minister of Health together with the partners in development of national guidelines for management of integrated management of acute malnutrition in Uganda. And these guidelines have been revised over the years with the inclusion of use of family work by the family caregivers, so that they are empowered to be able to learn, screen, and monitor their children for undernutrition or for poor nutrition or for maintenance of normal nutrition of their children. I'm among the national trainer, and also involvement of these guidelines with the ministry and other partners. The ministry is beginning to roll out countrywide about integration of family work used by family caregivers to learn to screen and monitor their children for normal nutrition. So in this program, we are at a preliminary phase where we are trying to do small processes of learning how to implement this at the health facility and the community level. So today, we were trying to do a small pilot at the Child and Family Foundation Uganda, using the community medical center at CFU to learn how this can be rolled out or can be implemented elsewhere. So this program is to be implemented by the Minister of Health. So today we are simply trying to pilot how can we implement it, how can we learn the processes, and how can the processes be improved where there is a need. So it's going to be a countrywide program, and it's going to start in West Nile of the sub-region in Uganda, but today in Kampala at Child and Family Foundation Medical Center was simply a pilot phase to know how these processes can be implemented or delivered at the health facility through the VHT, and also with the training of family caregivers. That's what we've done today. We have not yet worked with many people. As I've said, we are still beginning. Today was to see, after developing the guideline, after developing the training packages, after developing the tools that will monitor this program, we wanted to test how good are these tools to be efficiently to be used at the health facility, at the district, at the community level, and how suitable are they for community resource persons such as VHTs or village health teams and the family caregivers. So today we interacted or worked with the 10 VHTs linked with the Child and Family Medical Center here in Tula, Kawempe, Kampala. We've also invited the 10 family caregivers who have children and have been receiving care at Child and Family Medical Center here in Tula. We've also worked with the 12 community nutritionists and also 10 healthcare workers based here at the Child and Family Medical Center, headed by CFU or Child and Family Foundation Uganda. So that's in brief how so far. So here at the CFU Medical Center, headed or owned by CFU, the plan is to pilot in rolling out. So health workers have been trained today, and these health workers have been now involved in training the VHT, who are the community health workers, who roll around and work with the family caregivers in the scaling up within a small community to see how feasible, what challenges, and what are the factors that will facilitate it to do better, and what needs to be improved. We've used the very standard Ministry of Health guideline, job aids, and training packages to pilot this, to learn the processes. And the village health teams have been very enthusiastic. They have been motivated to see that they can use this. Similarly, the family caregivers with children, they have been given the knowledge, they have been given the skills how to identify children that are children malnutrition, and how to measure, and how to classify, and to know when to go to the health facility when a child has nutrition which is not good or appropriate or optimal for the child. Yes, so that's the beginning phase of pilot. And the medical center is very enthusiastic to see that they make a follow-up of the VHT in mentoring the family caregivers. They are also motivated to see that they're able to try out in screening in the neighborhood. They're able to try out in empowering and training more family caregivers at the community level. The health workers at CFU Medical Center have also been motivated to make up records which they'll be using, and also to mentor the VHT, and also the VHTs to mentor the family caregivers. CFU Medical Center works in collaboration with the Malnourished Nutrition Unit at Mulago. So CFU normally brings ready-to-use therapeutic foods for these children who are found to have poor nutrition. When we say poor nutrition, we are meaning children whose mark may be in yellow, or whose mark may be in red, or where the health workers have been trained in more detail to screen, and they say the child has moderate acute malnutrition or severe acute malnutrition, and they are able to treat either outpatient or refer to Malnourished for admission. So we are using that linkage between the CFU Medical Center and the Malnourished Nutrition Unit as a pilot phase to learn how good are these processes that we want to train in a bigger region, say where we want to start with the ministry in West Nile in Uganda. Then also in West Nile, once this process has been learned, the ministry and partners will see how to scale this countrywide.
We in Kawempe Division, because it is one of the health status of Kawempe Division is actually all its health indicators are very poor, and so we think that CFU partnering with Kawempe Division and FHI 360, we want to be able to make a mark within the communities of Kawempe and improve their nutrition status, but also other health indicators. We have the lowest immunization levels, vitamin D supplementation, almost everything. We have very high numbers of malnutrition, TB, and HIV within the community. So as a partnership, we think that we are going to go out into the community and be able to screen for these cases for children who have malnutrition and link them to care, because we know that 45% of these children, once they don't receive the appropriate care, they die, and we want to be able to reduce this number of unnecessary deaths that are occurring within our community.
My name is Dr. Nikaf Geoffrey Theophilus. I am a medical officer with Child and Family Foundation, and I oversee the activities in Child and Family Medical Center here in Tula. The role I play in the FHI project is to make sure that these children who are malnourished also are catered for medically. As we know, some of the complications of malnutrition requires medical intervention, and that's where I come in as a clinician. Apart from that, we equally have some medical condition which can push some of these children and pregnant mothers into malnutrition. So we are trying to come up with, we have schemes and activities on ground to identify some of those areas where these mothers are at risk of malnutrition, identify the children, find out what the medical causes could be or the complications as a result of malnutrition, and also to intervene appropriately where necessary. So that is what we're doing as this. As the VHTs we train from the facility goes out there into the community, they identify these children and mothers who are malnourished, send them to the facility. We look forward to identifying those medical aspects and intervening also where appropriate. So that is where we step into as clinicians of CFU to offer those services, and we are very optimistic that we're going to reach our expected goals.
So we think that in the coming 3 months we should be able to identify at least 200 cases, and we want to use an approach, a community-based structure where we involve the VHTs to actually screen these cases, cases that are within the villages. And we also want to introduce a concept that has worked elsewhere, where we group mothers and we give them an orientation on how to examine or check on their babies before they actually become worse, so that the mother is able, as we call it, that they are the first doctors. They should be able to monitor the situation of their children, so that they can always refer them to the health facilities within Kawempe.
Tusomesa ku mbisa y'abaana abatalina n'abasomesa abasawo bagendereza badde tetumanyi era ne batuyigiriza ne tuyiga okusookera ddala eddwaliro lino linnyambye nnyo omwana ono banatuukwako omwana ono asomera era okuva we najja nafunamu enjawulo, era enjawulo y'amaanyi ddala, naye ate wenzize era banyongedde okunsomesa mu ekyo kyenina.
To see that they are actually measuring properly what we've taught them to do. So we are thinking that we are going to make a dent into malnutrition within Kawempe and also improve the health status of Kawempe within the coming 3 months.
So for today we had a group of VHTs from selected zones in Kawempe Division, where we trained them. We trained these VHTs and they selected the caregivers, the mothers with children and fathers with children, where we trained them how to use this concept of family work, where it is being integrated into the nutrition management and other health services as delivered by the VHTs. So today basically we had to train these VHTs that we had so that they can also train the mothers or the caregivers that need also the training, so that this process of assessing, self-assessment of children with malnutrition goes on in the community without the necessity of health workers at a facility level. So we want to empower our community to see that they can assess their children at a household level by the use of our VHTs. Those are our village health teams and also the mothers themselves. So today we looked at this here on this job aid. We look at the different ways, the quick different ways of assessing children with malnutrition. We have edema, as you can see. This is edema due to malnutrition. Edema, we train them how to know which kind of edema a child or someone is suffering from, and to enable them differentiate it from any other medical edema. So we said edema due to malnutrition has to occur on both sides of the legs of the child. So both sides of the legs have to have the edema, and apart from occurring on both sides, this edema has to be pitting. When someone presses this edema, there has to be a depression that remains on both feet. So they had to understand this concept so that they can teach, because it is one way of assessing malnutrition in children with the condition. So we want to see that a mother can assess by herself before even coming to the health facility. She already knows, now my child is malnourished. So we also trained them on the other concept or intervention of how to assess, and that is by the use of family work. Of course, there are two types of malnutrition as we trained them. We have that edematous and the wasting one, the severe wasting. So a child with severe wasting cannot be assessed using edema, because for them they are not what? They are not soaring. So we use the tape to assess. So we trained these VHTs and the caregivers that were available today how to use this mark tape. This is the mark tape. So they can use this to assess those kids that are wasted. So this is how it goes. We trained them how it is positioned on a child and how to read it and interpret it. Of course, we have three different colors that are very important in this concept. We have the green color, we have the yellow color, and the red color. So we had to train them the meaning of each of these colors. By starting with the green means the child is okay and healthy as far as malnutrition is concerned. And then the yellow color means that this child is suffering from moderate acute malnutrition. And then the red means this kid is undergoing severe acute malnutrition. So once a parent or a VHT uses this on a child, as we demonstrated using these pictures, they can know where their child is falling, and then they understand the necessary intervention needed for that specific child. If the child is in red, they have to refer immediately. Also, if the child is in yellow, they also have to seek intervention from the health facility so that this child is helped. Apart from just the counseling and the health education, they're also given other interventions that will help on how to improve the status of the child. So basically that is what we went through. As you can see, this is severe wasting, this is edema. So a child with edema is assessed using this technique of pressing on both feet to identify the depression on both feet. And then this step 2 is the mark usage for those that are wasted, as this kid is wasted. So we cannot assess this kid using the technique of. So from those steps, now after measuring, doing the necessary assessments, now a VHT is equipped with how to interpret when it is yellow and green and red. And then after identifying these, what do you do? So they have been trained what to do after assessing. If the child is in red, please refer the child to the health facility. Also, this one who's in yellow, because he's not okay, is also supposed to be referred to the health facility to be seen by qualified health workers. Of course, the green one is still healthy. Then this one, the mother is just counseled on continuation with good feeding as it has been before. So all these interventions, the reason is to help our community, to help our health workers at the community level to be able to assess and screen for malnutrition. In the end, we can prevent malnutrition, we can facilitate early identification of malnourished cases from the community level, and then encourage quick treatment and therapeutic interventions as necessary. Thank you.
You press the two feet of the child, and you count silently in your heart 1,001, 1,002, 1,003, making 3 seconds. Then you release. So observe if there is a remaining on the feet, the pit. If the pit has remained on both feet, it means that there is edema. If there is no pit remaining on both feet, it means there is no edema on this child. And therefore, if the pits are not there, this child is not having edema. If this child is not having malnutrition. If there is a pit, it means the child is having malnutrition according to edema categorization. So, after assessing with edema, if the child has no edema, we assess using a mid-upper arm circumference. We also assess for wasting using a mid-upper arm circumference tape, which we commonly call MWAC tape. This MWAC tape is used on the hands, on the upper arm of the child. So I have to locate for the upper arm of the child. I will gently remove the cloth of the child so that I can locate the arm where I'm going to take the measurement from. So I have to locate the upper arm. I'll let the child fold the arm at 90 degrees. Then I get my MWAC tape and locate for the 0 point, which is the arrow. I locate the separation of the shoulder from the upper arm, which is the tip of the bone separating the upper arm and the shoulder. Then I also locate the tip of the elbow. So at the tip of the bone separating the shoulder from the upper arm, I place the 0 mark of the MWAC tape. And at the tip of the elbow, I'll run my tape until where I get the tip. And according to this child, my tip appears at 13.4 centimeters. So that is my upper arm. So after locating the upper arm, I have to locate the mid. So I get that 13.4 centimeters, divide into 2. 13.4 divided into 2, I get
6 point something.
13.4.
13.4 divided by 2.
36.7.
6.7. So I look for 6.7 and I gently make a press or a mark if I have a pen. If I don't have a pen, I will gently press at 6.7 without removing the MWAC tape, and I turn around that point, so around the midpoint, and then look for the small window which I use to tighten or loosen the MWAC tape. My window is a little fixed, so I have to make an opening with it. So here we are. So I will use this small window to tighten or loosen the MWAC tape and use the big window for reading. So during the reading, I make sure that my MWAC tape is just fitting on the arm of the child. It is not too tight, not too loose. So according to my measurement, according to my reading, my reading is 11.3. That is according to 11.3 centimeters, according to a health worker. But when we have a VHT, we use color code. Therefore, my child will be in red using a color code, which which later on we shall use to classify which level of malnutrition our child is. According to our measurements that we have taken, this child lies in red, meaning the child has severe acute malnutrition. In any case, I got a child that lies within the yellow color, it would mean that this child is having moderate acute malnutrition according to MWAC classification at a VHT level. If we use a health worker level, we need to refer to our cutoff points. And the cutoff points for a child who has severe acute malnutrition using MWAC lies at less than 11.5 centimeters. Then a child who is having moderate acute malnutrition, that is the child that is falling in the yellow category, the child has a measurement that is less than 12.5 but greater than 11.5 centimeters. But for our program currently for the VHT, using the family MWAC concept, we always refer to the color code so that the lowest consumer at the community level can easily interpret the findings of the measurements they have taken and can easily know if my child has severe acute malnutrition or has moderate acute malnutrition and can easily refer for treatment. If my child lies in the green category, which is greater than 12.5 centimeters, it means that this child is not suffering from acute severe malnutrition. However, we continue with health education to this child. We inform the caretaker how to take care of the child so that this child at any time does not relapse or fall short and gets into the malnutrition statuses. Thank you.
Okay, so this training was basically geared to training health facility workers because this is when the patients come from the community, they will come to the health facilities within Kawempe. So we needed to enforce the skills of these health workers to be able to know what to do and how to deal with these cases as they come.
Ndi VHT okuva mu Kiyanja zone era mbadde nga tulifalinga wano abaana wano tubaddewo leero n'omusomo nga gukwataganako n'ebyendiisa. Tuyize okukebera obubonero bulaga nti omwana ono endiisa ye si nnungi era ne tuyigana buta bwe tukebera omwana nga tetukozesezza bubonero naye nga talaga bubonero naye nga tusobola omukebera nga tukozesa akakuba ke bayitamu akateeyi akatulaga nti omwana ono endiisa ye si nnungi oba nnungi. Era twongedde okuyiga butyo bwe tuyinza osomesa bannaffe abalala ng'abamaama ate nabo ne babeera nga bakomerayo. Tuyize engeri gye tunaabasomesaamu nabo ne bakola obukugu nga balina tulaba abaana abo tulyoke tubaweereze ku ddwaliro ng'era ekigendererwamu tubunyise enjiri mu Kawempe Division. Era tuweereddwa materials ng'ez'okulikodinga mu kubanga tosobola kukola kintu nga torikodinze oba nga atakoze. Ne tuweebwa n'obuntu obwo bwenjogeddeko bu mwaka buba bukoba naye bwe tukozesa okufuna ki endiisa y'omwana era n'ebipande eby'okusomesezebwa. Era nga bulijjo nga VHT olina okusomesa. Bw'osomesa olina okubifaalinga. Ate kati tufunyeyo ekyenjawulo ekirala nti tugenda somesa bamaama nabo basomese bannaabwe abalala. Basi buli mukyala nti bw'obayita bonna ekyalo kyonna kiggwayo. So kigenda tuyambako nti nno bajja kuba batuuka ku bannaabwe.
In this process, we use family MWAC as empowering mothers in screening and identifying children as an entry point. But together, we add in all the components of preventing malnutrition or poor nutrition in children, and also for mothers to know how nutrition or poor nutrition can be prevented, or how to maintain normal nutrition. And if a child has also recovered from malnutrition, to prevent further recurrence as far as nutrition is concerned. We also embed other packages of health education or health promotion or counseling to empowering the health facility workers, to empower village health teams and the mothers. Importantly, the emphasis to see that the VHTs and health facility workers have empowered mothers or family caregivers at the health facility. Whoever comes at the health facility is screened together with the child, and at the community level, the village health teams, and when the health workers do outreaches to the community level, they are able to continue scaling up this as the best within the model of the Ministry of Health in integrating all these processes. That's what I can add on. And then we are in a learning phase of identifying any barriers or factors that may be a barrier to implementing this program. And also to identify any factors or processes that are good in what we call best practices to be able to ensure that we've institutionalized this process in the healthcare system, and to see the impact it will pose in identifying more children who may have malnutrition or in preventing malnutrition in the country. So we are looking forward to see that this is successful, and we are to work with other stakeholders, partners, and in line with the ministry and with the local government or the districts, wherever this is to be implemented.